All right. So this is our continuation of the Meet the Masters series by Boston Scientific and so on. We knowing that calcific nodule is in too much discussion at present. Myself, Dr. Keeney, my left side, and our fellows on the right side, and rest of the staff, you'll see most of them are about the same familiar faces, and they come for live relay of these cases. So let me present this case, and very interesting, will require a lot of discussion, will take a lot of input. If we can start the slide presentation, we're already a few minutes late, usually getting into. So this is our disclosures. Actually, this is the first slide. Yeah. So Boston Scientific, ESCC, and Mount Sinai Heart. Actually, now we call it a Mount Sinai Fuchs Heart. So this is a case number 12 in our series. 72-year-old, presented with new onset CCS class 3 angina, and stress test was positive. Patient had a surgical valve replacement in 2016, and valve is good. Ejection fraction is normal, and has few other conditions, as you can see: hepatitis, thrombocytopenia, and other the usual hypertension, hyperlipidemia. Cath was done and revealed 2 vessel plus left main CAD, very large calcific nodule in the distal left main, going more towards the circ, and we'll show you that angiogram. And there was some ostial LAD also, so we call it a 111, normal EF and a score of 25. So after discussion, because of thrombocytopenia, hepatitis, surgeons and they decided go for intervention. That is what we are planning to do today, as the distal left main calcific nodule using high density IVUS guided rotational atherectomy. This is the kind of case we might use upsize, multiple burrs. Usually we use only 1 burr. 95%, 5-8% require 2 burrs, and then try to put 1 stent because of the left main to circumflex and thrombocytopenia. What is the platelet count today?
Today is 70.
Yeah, platelet is 70. As you know, thrombocytopenia itself has been a risk factor for patients with event rate as such, and of course we know from the higher bleeding point of view. So this patient will fall into the category of intermediate high risk finding, and syntax of more than 22, but after discussion I will call it is appropriate because decision was made for intervention. So this will be in that left main category on the left side, that patient with a significant left main and complexity, yes, but after discussion, as we see that guideline directed medical therapy with and without PCI is appropriate in this particular case. So with that note, we'll just going to start our show the case, and I know a lot of other data have been in the calcific lesion imaging, which is still remain 2A. The question about the support, not necessary because ejection fraction is normal. Vanu, show it.
So can we show the angiogram?
Yeah,
right coronary artery, which is normal.
Yep.
And then we are going to the left side. This is just a dry cine to understand the amount of calcium. So if you see here, tram track calcium, distal left main, most of it is in the LAD. Then you see also in the circumflex. And this is how the angiogram looks. So eccentric lesion even on angiogram in the distal left main. Now the cranial view, we have done multiple views, does not look too bad. If you see,
yep.
LAD has another 60%, probably another eccentric lesion, and this is where we are in the caudal. Without imaging, looks like LAD is not involved. Lesion is mostly in the circumflex. So and this is where we are.
And looks like the LAD lesion is there, but slightly further down, right? Yes, like in this view.
Yeah. So this is.
So whatever we need to do, I mean, we always the whole issue of the 2 vessel, 2 stent versus 1 stent approach. As you know, our goal always had been trying to use a 2 stent approach. That the lesion will be there was ostial circ, and I think this is the case. We should do the image in terms of deciding the burr size. But bigger problem with the burr will be that it's a very angulated circumflex. So if we're trying to do in the circ, the burr size has to be undersized, and if trying to do LAD, then probably can go with a single burr, maybe even a 2.0. So that's another point here. What do you think? Let's take our
let's go back to the caudal.
Yeah.
I would suggest 1.5 single burr.
Like here. So that's a continuous lesion. Yeah.
Yeah, Dr. Shamin, like the
Yeah.
way it looks like, don't you think it would be a case for a 2O burr?
It is. No, definitely. But only question is the 2O if you are going to the LAD. But if you are trying to go to the circ, then I think I can tell you 2O will create a gutter. Will make a parallel lumen right from the before the lesion. It will be a wire will be in the vessel wall and create a wire bias situation. So yes, overall it is a 2O burr. But if we are going to the LAD, if you're going to the circ, you definitely have to undersize it.
Agree. So would you
Good.
not do
Why?
a burr from probably left main to circ and probably then left main to just a left main with a 2O?
Yeah, so I
Putting a
think
wire
that
into the LED?
that's a reasonable approach that we can do a 1.5 burr into the circumflex and then do a 2O. And there is a lesion, as we saw, into the proximal LAD further down, which we see it in this view. So there, see that eccentric, there is also eccentric lesion you see only in that view. So there, we can put a 2O burr from the distal left main to the LAD. So plan would be 1.5 into the circumflex and 2O going into the left main to LAD. So that is the way plan. And then after that, the question will come now, knowing this actually LAD lesion looks a little more clear cut now compared to what we had before. So maybe this rather than what we initially promised that we'll use a single stent technique. And what is your plan? 2 stent or 1 stent now? Knowing this proximal LED lesion, which was not obvious earlier.
2 stent technique, yeah. Now we have challenged, once he decided the patient is not a surgical candidate, we did challenge him with Plavix. He has been on Plavix for a few weeks now. He has a PRU on Plavix 82. So.
Yeah.
What is this?
Prof, if I may ask, apart from rotational atherectomy, any other option you would consider?
Yeah, so other question could be the, IVL, very clear. You should have one balloon ready.
No, hold on.
Yeah.
No, not 3.0. 3.5, right?
Yeah, 3.5, 15. Yes, 3.5. Yeah, other question is IVL. Can IVL make the turn? So that will be the only issue. Let's do the IVUS on this now.
No, what I'm saying now, we can go on the, or we'll do on the.
Speak loudly so everybody can hear. What's your plan?
I have one question, Dr. This is Bhupati here.
Let's see if the IVUS will go on the rotawire.
Yeah, sure. So see, we are going to put the IVUS, the rotawire there.
No, why you need IVUS here for the circumflex?
No, I think we just want to see.
Rota.
No, I think we just wanted to see the calcific nodule, how does it look, and what the atherectomy is going to make the change. Sure. So just to academic purpose, I mean, knowing the decision has been made to do atherectomy, but yes, we know the calcific nodule, all devices do work, atherectomy, rotational, orbital, and clearly, which we have published also, and then IVL does work also in this situation. So therefore, now question is which one is a little more effective? There are some papers are coming that maybe RA is slightly more effective than IVL in the calcific nodule. Our data, which will be presented soon, also the issue remain is the vessel size. When we use IVL, there's a bigger vessel compared to when we do a rotational atherectomy. But in this case, I would say that if you want to go with the IVL only, I mean, nothing wrong in that. But such an eccentric calcium, unless you shave it a little bit, will not be optimal, in my opinion, even in the end by using the IVL. Now, want to combine rotablation plus IVL, which is a RotaShock or rotatripsy, probably will be a better approach.
Dr. Samin, I have a question for you.
Dr. Samin, I'm just asking that whether you will also concentrate about the LED lesion, because it is very, very eccentric and it will be very much ugly, I think.
Yeah. No, I can tell you what happened is, in the earlier picture, we could not see that clearly when angiogram was done originally, but here, very significant LED lesion, yeah.
Whether you will go for the LED also for IVUS.
Okay.
I will not do IVUS now.
Dr. Sharma, I have a question. This is Bhupati here. How about doing a rotablation to circumflex, rotablation to LAD, put a DEB, since it has been approved now, to circumflex, and put a stent from left main to LAD, so that we can keep the metal less, we can really clear, we can get down to single antiplatelet sooner in this particular HBR patient.
Yeah, so question comes is that can you come out in this case with one stent approach, and if so, what is the other alternative strategy? Alternative strategy will be the DEB if it is possible. Otherwise, you just try to do a maximum lesion optimization. The DEB, as you know, is not available in United States yet. We're just having the trials ongoing, but that is also ISR. And agent DES, which will be approved soon, is still a little away, has not been approved. So we don't have a DB. Yeah. But clearly, I know that Europe is getting all crazy with the DEB, even in the large vessel. Colombo and all they are teaching that do the DEB in large vessel. I think still
Show the IVUS.
data. I'm still skeptical about it. Particularly in the large vessel, but a lot of people are doing it in Europe. And the 25 years we had taught everybody to do stent. Now we are going back. Okay, now let's go to the IVUS. Yes.
Yeah, very small. Now coming bigger. This is a proximal circ.
Yeah.
It's not that calcified, just a 1 degree. Yeah, here's a nodule. This is distal left main.
That's a nodule.
Yeah, so tight lesion. Yeah, protruding inside. And I'll come to the proximal left main.
The proximal left main is without disease.
Yes.
Now we are supposed to get a new HD IVUS of the Boston Scientific with the co-registration and so, right?
Yeah.
Which will be
upgraded the software. Yeah.
Which actually we have the new software which will be upgraded this weekend, right? This weekend or next weekend?
Next week.
Yeah, next week. So
How
we'll
much
have
is
that.
How much is the diameter of the left main and the LCX ostium
Sure.
or proximal LCX?
So now I try to find a healthier left main. I check the EL to EL, like a follow vessel, and about the cross section. But it is gonna be 4-5. This is a proximal left main.
Okay.
Healthy part. Now come to the distal circ. After the lesion, before the branch, not the perfect healthier part, but a vessel side like EL, like 3-5. The proximal circ is 3-5 vessel.
At the ostial circ we need.
Yeah, ostial circ, sure.
Okay, now Bhupati has some question also. Now guys, can we bring the screen a little away from the, so we can see also on the side
So
these pictures? Yeah.
This is the ostial circ. You see the 6 o'clock. This is the calcified nodule protruding inside.
Yeah. Yes.
So if you look at the diameter of the lumen, you think 1.5 bar is going to touch that nodule or is just going to pass through? Because you see your IVUS, everything went so smoothly.
Yeah.
Yeah, but the issue is the distal left main. Yeah, it's true. The IVUS glossed, but distal left main is so tight.
Yeah.
And MLD is gonna be like 1.3. This is a distal left main, the minimum lumen diameter.
Okay.
Yeah. So very good point. So everybody, talk about the lumen. Let's go 1.5 bar.
No, we have to make a point because they keep talking. Go bigger bar, bigger bar.
No. But the question is always no. So key is remember with the rotational atherectomy. So it is not only the burr size, because the way the burr is going to lie in the lesion, because the wire bias. So it is going to shave it. There's no question. It will not pass through. It is going to differential cutting, and it is going to shave that nodule. Now, will it do, comparative, if you take the data of the OA versus RA, will RA do a little better job of the shaving this calcific nodule because of the vertical axis in addition to the horizontal movement? Is a matter of debate. We did have original data with the OCT, but was not necessarily calcific nodule. We found a better, deeper cuts using orbital versus rotational atherectomy. So even the lumen is 1.58. You use a 1.5 burr, it's going to shave it. Why? Because the wire will be in the lowest, most concave portion of the lesion, and so it's going to shave it. Anu, you want to add some point? Yeah.
Most important point, I think since the beginning of this live case, they keep talking bigger burr size. If you see here is a 90 degree, okay? Go back to the angiogram. Yeah. No way that you want to do a bigger size burr in this 90 degree angle.
As a first one, yes.
Or even a second one. So that's the point we are trying to teach. Yes.
The bigger size burr we were talking about going from left main to LED, not into the circ.
Right. Agree. Good. As long as this is the point clear to everyone. Beautiful. And we should ask our audience also put a question in the chat box. And
so one more question: how to get the favorable bias? Suppose what kind of wire you use? Is a floppy or is a more of a support wire?
It's a very good point. So key is that I think there will be already enough bias, but yes, extra support wire will give you more bias, And so we usually, teaching will be that we'll use a floppy wire in this case. Now, by using extra support, would you get a little more bias? I think probably, but to me, I think the floppy wire will give you enough bias in the inferior suspect and able to do it. Okay, so now we are 1.5 bar. We are ready here and going. We can open the shutters. Yeah. Okay.
And that's the proper decision, because even the angle between LED and LCX is more than 90.
Yeah.
It's so much obtuse angle there.
And we have the 7 French. This is a Voda 3.5.
Mark.
Yeah.
Mark. Okay.
Yeah. Voda Mark 1 guide, and here is the key that your bird does not jump. So you have to take all the aspects out.
The tension, yes, and we'll do it from the probably from the guide itself.
Yeah.
Okay.
So Dynaglide tap first. Good. Okay. Let's start. And same, balloon should be ready on the table. So we have a 3.5, 15 balloon ready.
5 seconds. 10 seconds. 50.
Dr. Sharma sir, Subhash Chandra here.
Yes, Subhash.
What's your plan? Are you planning to have elective 2 stent here? And if so, which strategy? Because this angle looks pretty good for even a tap.
Yeah.
So what's your plan?
So very good point. So question comes is, believe me, if not a thrombocytopenia, there was no question in our mind, put 2 stents. Because of thrombocytopenia, you always are concerned, although patient had tolerated clopidogrel and the platelet count remains 75. Now you saw that I changed the wire position also with the brake release, and that will give a little different bias also. Yeah.
Yeah. Okay, that's cross.
Even tweaking on the orientation of guiding catheter would be of help. Here.
That is correct. Yeah. Okay. Yeah. And hemodynamics, you are seeing it here.
Okay. I think we start coming out. Okay.
Yeah.
Yes. No. Question now what? Take a picture and then decide to go to the LED. Okay, leave it. Let's take a picture.
Good. All right. Ready to take a picture? There was a little more flush.
But circ is okay.
Yeah. But looks all right. I mean, there is you can always decide, but a point is doing here is not going to change our plan. I think we should keep only, no, wait 1 second. So maybe we can, same wire, we can get into the LED now. How you want to do it now?
Okay.
And I think
you want to put a burr in the LED?
LED, yeah. So we'll get a 2O burr now. We'll attach it. And see if we can move it. Otherwise, we'll go with the same strategy.
Get the IVUS.
Here's the clip. So you sometimes use a torquer as a clip necessary, because usually we don't use much in terms of the torquer.
Dr. Sharma sir, I think your decision to pick up IVL is based on how the balloon behaves in this lesion after you've done the ablation.
Yeah.
Is that right?
Yes.
So I think one must keep IVL also handy.
Yes. Yep, absolutely. No, this is a kind of case that you now the original, just with the IVL in such a lesion, although LV is normal, little hypertension may occur, but that's still tolerable because EF is normal. But EF is low, IVL in unprotected left main, and if RCA was closed, would have been troublesome. But in this case, we said that we'll use IVL if necessary, but as a adjunct after doing the atherectomy, rotablation. So that is the plan. So your wires need to go to the
before considering IVL, you definitely have to image and see what rotaburr has done to the vessel.
Yeah, that's right.
Yes.
I went to the septum.
Would you like to go for an IVUS for the LED eccentric lesion, or you will go for the
I think we'll do it
We'll
in the
go for
just
the
after this
rota
rota. Yeah,
upfront.
after the rota, then we'll do. And what we do now? Get ready your fielder fine cross in case there's an issue. Remember, if there's a not able to advance,
Get
I
into
said,
the LAD, yeah. I mean, going into the septal.
right. So get
Say,
all
can
ready.
you kiss
Done.
that?
Still septal or what? 1 second. You want to go to another view or is okay?
No, I think we are okay. It's just that
No, this septal.
we know that. I'm trying to see. Then I get into the LAD. Otherwise, we get the fine cross and change it.
Yeah. So key, I tell everybody that if you cannot get your rota wire, don't waste time because it may create even more trouble, unnecessarily die here and there, and use a fielder fine cross or whatever your over the wire system and
Okay,
exchange
now
it. Good. Now the diagonal.
Yeah, maybe diag.
Yeah.
Oh, yes, that's not the thing. Septal. Okay, get the fine
Can you go
cross.
to the epicranial and you can easily do it?
Yeah. I think let's go 1 second before you do.
It's not going to change.
No, go to this view.
Okay.
Just 1 second. Yeah. Go.
How epicranial is going to change? Give me the fine cross.
That's the diagonal.
It's the curve, the tip.
Yeah, tip probably with the circ has become straightened. I think that's what is happening. You want to ask a deep breath?
Fine cross is ready?
Yes.
We can go to the tip of the fine cross and change it, I guess.
Ask a deep breath at this level.
Okay.
Take a deep breath.
Still, I think, diag.
Still the diag. And particularly it's the rota floppy, rota extra support will give you no support anyway, because it's the longer tip of the rota extra support, 2.8 centimeter versus 2.2. What do you need now? Okay, so we're just going to direct it.
Using a fine cross.
Okay. Okay, so far hemodynamically patient is good. Go.
Let it stay there. Once I get the fine cross up, then we can change it.
Good.
Dr. Samin, do you think that the shaving has been enough for the left main?
No, not left main. No, for
same.
the circ, yes. For left main, that's why we're using 2 bar. We are ready with the 2 bar. Yeah. So no, definitely left main shaving is not enough. So that's why we are going to the 2
Not enough.
Yeah. Too far.
No, it doesn't matter if you want to change the tip. Okay, give me the fielder wire, I guess. It's taking too much of time.
It looks like it should go easy.
Yeah.
But
I think part of you want to change the wire tip here.
Why you,
Nikita,
why you are going to take a fielder? Why are you going to take a fielder or a normal worker?
Yeah.
So
Look at the tip.
Good.
So
Okay,
good.
here.
Yes.
Go to the fielder.
Any worker so
Yeah, that's what we are doing. That's what always we teach, and that's what we are going to do. So anytime you try to cut short, it's not good. Yeah.
No, we always try with the rota wire. If it happens quick, we are good. But this somehow, tip has not been destroyed, but still not making the turn into the LAD.
Okay. So now, and then we'll need a cutting balloon also.
For what?
For the ostial circulator.
No.
3.5. Is it maybe in a different way? Yeah, good. Okay.
The amount of calcium may be there. See there?
So what do you feel about the cutting balloon versus OP&NC balloon for the circumflex?
Yeah, so I think one of them will be good enough, both of them. So I still, the key is, I still believe that opium just be going to expand it. And in this calcific nodule, you need a little more cut in the nodule, the crack, which we call shaking or shaving. So combine both, yes, open NC is reasonable too. But we need to expand that further. We actually have not started using OpenNC here. It's available for almost a year. One of the simple reason, the cost-wise, is the added cost, but no separate reimbursement. So it is about $1,200. They brought it down to 1,000, and the cutting balloon is 650. So because of that, we said till they become 650, why we should use any adjunct balloon, which will going to cost us most. Now, rotablation, atherectomy, shockwave, IVL, they all have a separate reimbursement. So we get extra payment for them. So that's not an issue. So issue remain is the open NC, and that's why in USA, the uptake of open NC, which I talk to many people, is quite limited.
Yes. Because I've gone through your RotaCut, this article. You have mentioned that there is not much of difference between cutting balloon and this non-compliant
high pressure balloon. Yeah,
of...
that is correct. So in terms of the primary endpoint, is basically the minimum stent area expansion, but identical with the two approaches. So only thing is that it was able to expand it. So therefore, our I would say that in osteal lesion, because there were only 60 patients in there, osteal lesions were a little less, and so therefore, an osteal lesion, I would just favor the cutting balloon. Otherwise, high pressure balloon is good enough based on RotaCut trial. But you saw that RotaCut trial, that of the 60 patients, there were no complication. 2 patients had a non-QMI, that's it. 60 complex cases. I think in the history of rotational atherectomy, having almost no complication except this moderate CK release in 2 patients was remarkable. Yeah. Good. Ready? Okay, now we are ready with the 2O bar. Good.
Now have a run through fielder again ready, okay?
Both run through fielder, everything will be ready. 1 second, let me do one last mag so we know the wire tip is not too far. We can do same. Yeah, good. So this is the 2O going to the left main to that LAD eccentric lesion. And after that, you'll decide, I'm pulling wire. After you decide that, do we need what modification for the LED also? After the 2 bar there. Good. Okay.
Let's go.
What is the speed you keep it?
About, remember this Rota Pro comes set at 150. So I had done with the company's setup, you don't even have to move. When you start, always you start with 150. And that's where it is now. Fine. No. Good, good. That's good. That's good. Yeah, bent very easy. Yeah. Good. Because the 7 French guide will take only 2 bar. 2.15 require 8 French.
Yeah.
Go.
Okay, come out.
2.15 and 2.25.
Okay, let's have the IVUS again. Right?
Yeah. Sure. Now we can do the IVUS after wiring.
Eagerly waiting for the LED lesion, actually, how much it is. Because
that's what we are
so
going to do.
Concealed and so.
Yes. Noted. Good. Okay. All right. Let's see. Take a picture or do a picture or go to caudal view. Okay, let's take a picture here. Good.
Looking good.
Yep. So far.
This time left main has been ablated a little bit.
Now, see that well. now finally it has been ablated well. That is correct.
Yeah.
We needed 2O.
Yep.
Yes.
Yeah.
So 1.5 passed through. I'm sure did some work at the osteal circ, but may not be the little shaving.
1.5 was at the distal left main.
Yeah.
MLD.
Yep.
So 1.5 definitely did
some
ablative work in the left main distal.
Yes. Yeah. After a lot of discussion about the eruptive nodules and calcium nodule, do you think sometime when you do the nodular treatment like this by Rota, do you keep that thing in mind? Do you consider that?
What's the question?
Consider what? Sorry, I didn't
Consider,
get.
yeah.
Actually, calcium, nodular calcium and eruptive nodule, two different thing,
Right,
because
yeah.
as far as result is concerned, eruptive nodule has a different kind of outcome.
Mm.
So in a situation like this, do you consider that? I mean, whether is the IVUS can
Unlikely.
detect that kind of?
Eruptive nodule most likely ACS.
It's true.
Yeah.
Take this
So
wire
in
out.
this kind of
Yeah,
stable
of course. This
situation,
patient
yeah,
has
you
got
don't
a
want to, yeah.
stable angina, very
Yes.
unlikely. Yeah, very unlikely to have a eruptive nodules.
No.
But still, IVUS can detect that. Is there any whether any indication that there is a eruptive nodule, or that means fibrous capsule usually
Yeah, the
denuded
difference is the
eruptive
surface
nodule.
is like irregular or not. Of course, OCT is better to
Yeah, you need for that. If you really want to differentiate, you need to get OCT, to see the fibrous cap. You'll not understand that with IVUS.
Yeah.
Yeah.
IVUS, yes.
Yes.
Okay, so we are ready now. First, we are putting a wire into the circumflex, and then we're going to do IVUS into the.
Yeah, we'll go to
LED.
IVUS into the LED.
Yeah.
And what you want, circ also?
You can do both IVUS or both. Yeah.
You know what?
And this calcific nodule are the one that every study has shown. Those are the one which have higher complication, particularly perforation.
No, wait.
Yes.
Can I wire?
That's fine. I know. I'm leaving it. Yeah.
We have to go to this view.
Yeah, good. That's good. Go to the circle.
Fix it to this view. That view. 29 caudal.
So this is a very acute angulation of the circumflex with a eccentric nodule in the left main. So for the beginners, what precaution you like to suggest to do Rota towards the circumflex? LVEF is fine.
No, that is what we said. Undersize, grossly undersize the burr, and then if there's not much calcium, avoid the rotablation going to the circumflex. Nothing wrong in that.
Yes.
And then if need to be, you just can later on just do the IVL if necessary. That's it. Undersize the burr and use the IVL if necessary for the circumflex. So clearly I say that once the IVL has started, 2 lesions we should be careful where you do if only must. One is the diagonal and second is the circumflex. Angulated circumflex like this, because those are the, if there's too much calcium you need to do, but these are the 2 lesions which have a highest perforation rate with the Rota. And our goal is, and that's what we are looking into our database, that since the IVL has, what IVL has done is decrease the complication of atherectomy. Why? Because you just go with a smaller burr and you are not doing it in areas which were little more, I would say, susceptible for perforation. And the classical is the diagonal. So very rarely we do the Rota of the diagonal now. If need to be little balloon IVL is reasonable because that's where the maximum perforation of the, it occurs of the Rota.
Right.
Okay, now we are doing the IVUS of the LED.
Sure.
Which we have not done before.
Okay, show it, Kiski.
Yep. So it's on the lesion, just at the level of the bifurcation.
No.
I start forward.
Am I at the diag, large diag?
Yeah, this is the diag.
Yeah, that's good.
Yep.
Okay, pull back.
I think this is a good landing zone on the costume, but good lumen. Yeah, this is the nodule again, the Plux LED. Yeah. Still LED.
I think it's a ablated nodule.
Yeah. And now come to the left main.
Distal left main.
Yeah, so osteo LED is patent, but the Plux LED is very tight with the nodule. Okay, I will stop.
Okay, good. So give us a CS at that nodule level.
Sure.
Of the LED.
Like here.
Yeah.
You want to circle.
But this is after the 2 loader.
Hmm.
One second.
Go to the circle.
5.2.
Yeah, like around 4. But eccentric, and our surface, it looks ablated and a liver ablation.
Okay, I'm going to the circ now, okay?
Sure.
It has shape.
Yes, surface is shaped.
No, we could not hear the question.
Cracked the calcium adjacent.
Dr. Sharma, it's a 4.5 millimeter vessel. It's a very roomy left main, isn't it?
Yep. Yeah, very big left main, 4.5.
Yeah.
4.5 left main. And the lumen seems to be less than half of the left main size right now after the rotablation. So if we go and put in a stent right away, will it expand, or does it? I think it needs further modification with IVL or OPN.
No, but at that level, I think at the distal left main level, we just do a little more modification.
This is from the circ.
Yeah. Okay. Circ is too far.
And I think an orbital
atherectomy
orbital atherectomy can be
osteocirc.
Yeah. Only problem orbital is it creates a little more wire bias in the angulated lesions, because remember orbital wire is 0.012 inch compared to 0.009. And okay, how does the circ looks now? Guys, comment on it. Circ actually looks very good.
Yeah.
Yep. This is a osteocirc.
Actually, there was not a calcium in the osteal circ. It was just distal left main.
There's like a 90-degree the osteocirc calcium, like a nodule. The pre was like 1.5. Now MLD is 1.9, like a little bit shaped the surface of the nodule.
Yeah.
I would just balloon this now.
Okay.
Yeah.
Cutting balloon or regular balloon?
Distal left main still
Go back to the distal left main.
Yeah, this is the distal left main. The surface is shaped, but still, because of the acoustic shadow, we cannot see behind. But still like a huge plaque burden, like a calcium burden, the distal left main.
But the calcium arc or the chunk of calcium is sitting right across the circumflex ostium, isn't it?
Can you show me the, this is a...
LED, 3.512.
Won't do anything. Need 4.
No, that's fine. 3.515, yeah. Okay, what we want to see now?
Show me the pre left main, distal left main, pre.
This is the initial one.
Initial, distal left main.
Yeah, like this.
Very eccentric. Nodule.
Yeah, and as you said, irregular surface, even by the IVUS.
But
and I will show you the post-loaded.
3O cutting balloon for the circ.
It looks like more smooth because we shaved by the 2 over here. The surface changed. We shaved the surface of the nodule.
Going up. So this is a 3.5, 15.
I would have gone 4.
Non-compliant balloon, 16 atmosphere.
Yeah, see? Opened up well.
Yeah.
You don't need
You have to go a few millimeter more for the LED?
Let's do that. So we put a 4O in the LED.
No, 4.5. One is stand.
Oh, circ, no?
Oh, circ, yeah, sorry. Yeah.
Hello. Okay, down.
Good. That's good.
No,
The question is that even for the osteal circ,
Don't you like to dilate? Don't you like to dilate the circ also?
Oh yeah, absolutely.
Yeah, we're going to do
so your question was the circ we just go with the high pressure, or go to open NC, or go with the cutting balloon Wolverine. So we actually have a 3O. Wolverine was our plan. So although I think the high pressure could have been good enough, we know that whether rota cut steady in terms of MLD, but since we have it, we're just going to use that now. Now, more question will come to, and that's where we need everybody's opinion, that we want to come out with a one stent possible in this case because of baseline thrombocytopenia and not put a 2 stent. Otherwise, it's an ideal case for 2 stent approach. So in that situation, should we put a stent from the left main to circumflex and optimize the LED result with the balloon angioplasty only, knowing that we don't have a drug-coated balloon?
I think there's a fair option.
That one, or second is give a little gap from the osteal LED because the lesion was a little further down, right, in the LED, not at the ostium.
Yes.
How is the osteal LED?
Osteal LED is patent.
Then clear, then give a few millimeter gap, and so that no stent abutting. So that's where the whole question happens when you put a double stent approach and a higher chance of thrombosis, particularly with a thrombocytopenic patient. So this is a cutting balloon, the Wolverine is still not making the turn into this calcific lesion, but let's do it here. And then we'll make it. Yeah. So once the nose is there, you can do, and that's what exactly we're trying to say, that if somebody wanted to do,
Okay, good.
Go up.
We just got more wire purchase and then we are able to get the,
14, 16.
What is the size?
It's a 3O. It's a 3O because remember lumen right now was 1.98 and overall vessel of the circ is what, 3.5? What is it?
I'm thinking just do synergy.
Yeah.
No.
Synergy Megatron.
Double stent synergy, and
Double
even
stent,
then you
okay.
can stop it.
Yeah.
later on in 3 months.
Because
if you want.
yeah, good. So one of the good advantage is that after a few weeks we have tried this patient we are given a challenge of the DAPT.
Yeah.
And the platelet did not develop thrombocytopenia and platelet remained 75,000.
Down.
So therefore, just do the distal circle, distal left main a little more.
Go.
Yeah, here, yeah. So
So it's better to go for the two-stent strategy.
Yeah, two-stent strategy. Yes.
Better to go to two-stent strategy better.
Yep.
Because
I think so.
The left main ostium is not good.
Yep.
LAD.
Yep. Okay. Ready? Now take a picture and
let's take a
decide
picture
on everything. Ready? Yeah.
Good.
So we go 3-0.
Yeah, the distal left
right?
is halfway.
4-0. 4-0, 20.
What?
Left main to LAD.
No, left main, there you can use 4.5.
Not LAD.
Not already.
Yeah.
4.5 is too big for the LAD.
No, you can use moderate pressure. 4.5, 15 or 16, right? Yeah.
No, why don't we use 4.0 and post it to 5.0?
Dr. Samin, why you are not going for a left main to SARC and then LAD later?
So question comes in that if, that's very good point. So once we decided we are going to use a two-stent approach. So clearly the LAD is a bigger vessel. So we'll put that as a main vessel and SARC as a side branch. So then with that approach, the question is the stent size and length we actually have. And I know will be available in India. Show the slides quickly. Meanwhile, you decide size. Yeah. Show the slide. Go back to my slide presentation.
3 or 16?
Yeah. So whichever way you decide. Yeah.
3 or 16 synergy.
Okay. Our slides. So which will be available in India very soon. We know the polymer thickness point of view with the biodegradable polymer of the synergy and then synergy XD. And there are two types of synergy and Megatron. Both will be available in India end of this month. So will be introduced at the time of the India Live. XD compared to our regular synergy. So with the stent, you see the struts are our 78, 83, 85, and once you have Megatron is 93. So why Megatron? Basically is because it gives you extra strength in the large vessel. Look at the nice the connectors and in the Megatron gives you better. Now XD is a better stent delivery system. So both Synergy XD and Megatron will be available. Maybe there is really a little premium. That's what we have slight premium here in United States for the Megatron. So very deliverable stent. And the most important point is that from the scaffolding point of view, the 5 millimeter versus 3.5, that in this particular case, although it's not a 5 left main, so maybe we're just going to decide to put a Synergy XD and not the Megatron. But this is the ideal case for the, if the LED was a little bigger, using the Megatron of the 4.5. Now Megatron comes in the 4.0 also, right? We have 4.0 Megatron? Yes. Yeah, so Megatron is 4.0, 4.5 and 5.4. So let's go back to the angiogram, please. So this is will be a good case for the using a 4.0 Megatron from the left main to the LED and using a 3 or 3.5 Synergy XD from in the circumflex.
The reason I'm saying Synergy is for this guy develops bleeding, we have data that we can stop the antiplatelet.
Right, that's good.
Yeah,
so that's
but not with Megatron.
Oh, Megatron also the same thing. It's the same data, yeah.
Thick strut.
Yep. Good. So now we are putting in the stent in the circ first, and let's get the 420 Megatron. Yeah.
So we are in the
circ.
Circ.
Good. This is the key. So 7 French will take 2 stents.
Can you show the side by side mini crush?
So we'll show the bifurcate.
Take the IVUS out.
3D. Yeah. Right now. We can take the IVUS out and just bifurcate 3D app with a mini crush. So we actually are working on the various strategy at one center of the mini crush, DK crush, culotte, or tap. So tap is one way, but I would say the tap is same. That you're putting a one stent, then going with the second. So best is that once you decide, get better with the either DK crush or mini crush. So we actually have no question, no hesitation using the mini crush in the most of our bifurcation lesion subset.
Yes.
So it's a classic mini crush.
Yeah. So it's I mean, just the not nano crusher show where you have to recross and all, but
Yeah,
just
yeah.
a mini crush, yeah.
Mm-hmm.
But not a big one, not a macro crush or what used to be the class
Some
one,
dye.
but just a little
Show
bit.
me dye.
So now we are connected with both the stents.
I think Megatron with 7 French is in trouble.
Yeah, good. Looks good.
No,
Yeah.
I had to go in a little bit. I'm not going.
To bring the circle a little bit back and you are ready to deploy.
Connect. Somebody has to give me dye also.
4.58 high pressure balloon. Now we don't have the the pot balloon.
Ready?
Here we'll just go with that 4.58.
Good.
Yeah.
Right?
Circ is too much in.
Whether
No,
you
we
have
can't
covered
change it.
whether you have covered the LED
Nothing is
eccentric
moving.
lesion.
Yeah.
Yeah.
Okay,
Yeah.
go up with
Question
the
is,
circ.
have we covered the LED eccentric lesion?
Yes.
Yeah.
I think so.
Yeah, even by IVUS,
A
the
little
20s are
bit-
just
a little
size
bit
to cover the
distally.
both left main and LED lesion.
Yeah. So actually by IVUS, they have the measurement that 20 millimeter will cover both eccentric LED lesion and the left main.
Yep.
Yeah. Good.
Okay.
Which is a circ? This one, right? If I go in, we may not be able
Yeah.
to bring back. It's so tight.
But circ is okay. Remember, stent
Okay,
is
good.
inside the dot. Yeah. Let's go up.
Go up with the circ.
Go up.
Okay,
14, 16. 16 atmosphere is okay.
Down. Go up again. You are ready with the Megatron, if you're ready. Okay, down.
So this is a 3020,
16.
16, 3016 into the circumflex, which had been deployed at 16 atmosphere.
Okay, some die.
Yeah.
See, I think this moved in. Okay, some die.
Good.
What do you think? Pull back a
Now,
little
once you're done, as you should see there, the wire will be
bit. Some
removed.
die? Okay, good.
Yeah. No dissection, so remove the wire.
Okay, go up with the Megatron.
Yeah. I encourage all people to attend our, which we did,
Yeah,
the
enough.
the
Foro, right?
CCC live
Okay,
last
done.
Tuesday
Fell again.
on February 20th. We did a 2 mini crush. So 2 mini crush, first time we are done.
Okay, done.
And that one, D1, D2, all large vessel
need a
to
new
2 mini
feeder.
crush. Was a superb case. We got a lot of hits on that day, a lot of discussion about double mini crush in the same patient. So one stent in the LED, and there was first the D2 we did, then we recrossed and put a D1.
Get us a 4, 5, 8.
Yeah, 4, 5, 8. Yep. So this always question comes, do you a pot, you do a kissing, and so forth. I think it's a reasonable in this particular case that you do a, because we know the proximal vessel is big anyway, so you want to do a 408 pot, and you want to cross before or after, it doesn't matter in my opinion, as long as you can get it. You want to cross now or later?
Yes.
Later.
Later, good.
No, I mean, if there is a big discrepancy, of course, you do it after. Otherwise, yes, you can do it.
Yeah, and also the signs, the proximal, I think as long as, in my opinion,
Optimal cell.
Optimal cell. You get
Crossing.
into the mid-size, don't waste time, whether it's a DK crush or mini crush, everyone has little, data based more on, rather than human on the Olmistron, with those data. So we are basically, our teaching is just go to the optimal cell, go easy, so you don't create the dissection. So this is a 4.58 at 20 atmosphere.
Give me the fielder wire. The fielder wire, actually, the tip is completely gone.
Yeah.
Since we crossed multiple times, I'll
You
take
want
a
to
new
go 2
fielder.
millimeter further?
Yes. But don't go that high.
Yeah, they're low. Yeah, good.
Yeah.
No, a little more. Yeah,
Good. You have a new fielder? Yes. Okay, good.
10.
Down. Down. We don't have a picture.
No, but that's okay. We don't need the picture. Yeah, good. Now, 1 second. Just make a dry cine. Look at the Megatron, the cells. See that? The cells of the bigger proximal versus distal. So exactly what was shown in that cartoon of the stent. So that's a difference. It gives you extra strength. So it's come, as I mentioned, 4.0, 4.5, and 5.0, and that may require. Let's take one picture or no? Yeah, let's do one picture now. Sinay. Looking good.
Nice.
So now we need to do a kissing. And now, sir, kissing, we have a 3. No, we never had a cutting balloon with the high pressure balloon. So get us a 3012, non-compliant. Good. Yes. Yeah, what we would say, just avoid the first cell in your mini crush. So because then you'll not be able to open the ostium properly. So that's it. But otherwise it goes to the mid portion, little distal. I think it's all theoretical. It doesn't make here. First, second cell is the one that will be maybe a little troublesome because then same. The ostium, because of the lack of the stent material, will not open nicely. Get a 4.5 ready also. Yeah.
May not go SS. We have a 3.0, right?
Yeah. You want
Let's
a 4.0?
take a 4.0.
4.0. 4.012.
We may need anchor.
Yeah.
No,
So,
you want to take 8.
the question
Get me a
always
regular
comes.
balloon.
Okay.
2.012.
Then give us a 2.012 compliant. So it's not uncommon that despite you do a little pot that and the wire was there, did not go. So with angulation. Otherwise, non-compliant will go.
No, the thick strut SS.
Yeah.
Megatron
But
thick
Dr.
strut, we
Samin,
may
for this
always have
angulation
issue.
is tough.
Yeah, exactly. And then the Megatron, but the gap is still the same. Yeah.
Even if the gap is there, the
Thick strut.
thick strut is not allowing us to make that turn. Okay. I mean, you have to be ready for anchor.
Wire has come. Good.
There's other teaching also, you can recross some other cell, but now we are with the compliant balloon, should go. Not going either 2.0.
I can
to try
to
anchor.
negotiate the
Anchor.
catheter.
Yeah. Yep.
See there?
Let's do the anchor.
Okay.
Yeah, leave it there.
But then
4.0 balloon?
anchor, no. 4.0 will be too big.
No,
We
4.0
had
will
the
be okay.
3.5, right? But that's a 15.
Yeah, that's fine.
Give
That's
me.
okay. Yeah, we have 3.5 balloon. We'll use that.
Because LED is barely 3 point.
No, LED is what's the size of the LED was?
Barely.
4.0.
3 point.
No, 4.
LED.
LED, I mean, Besser is 4.0, but lumen is like 3.8.
Yeah.
LED, Prox LED.
Okay. No. Prox, no. We are talking further. It's
Prox we're
not
talking
4.
about. Yeah, go.
The distal reference is 3.5 maybe.
Yep, yes, right. Connect. We have to go negative.
Don't do the negative. With the syringe. Go
Did
negative with
with the
okay,
syringe,
okay.
yeah.
Leave it.
Yeah.
Maybe trouble.
Good.
Okay, but we are now outside, so low pressure, okay? We are not in the stented
But you
segment.
can pull back a little more.
May not allow me to get the, okay.
Yeah, good. Yeah.
I think your 2 balloon is pretty long. You have to take a smaller one.
Yeah, this is the 2.012, right?
215 or?
Let us 8, 208. We have an 8.
Or 1.5. Do you want 1.5?
No, but 8
So
millimeter what you have.
1.5 is
8
better
is
because
also 12 or 15. No, don't give me that. Track balloon.
because an angulation, I think smaller balloon is better 1.5.
Yeah.
Angle is very bad. Angle.
Give us.
What is that? 8 millimeter, right? What is it? 1208 here. Oh, Sprinter Legend.
Mini track. Okay. So a smaller balloon. So because of this angulation, but at least the lesion wise, as you saw the angiographically, that looks perfect. Look at that. Very
Yeah.
little mini
Yeah,
crush.
only
So
because of angle.
exactly. So jumbled up the shadow at the ostium, very little mini crush. And we can ask our other opinion, if any other question from the our audience. Advance their balloon. Just.
Dr. Sharma, this is Dr. Rishi Sethi.
Yes,
from
Rishi.
Lucknow.
Yeah. Yep.
Just one query. I mean, don't you think that since we have pushed both the circumflex, the entire circumflex stent towards away from the carina, then going a little proximally while crossing the wire would throw a little more metal towards the carina and cover to the metal?
Very good point. So let's see that if we are going to enlarge it, and we'll show you that a wire is exactly in the center. See that?
Right.
Yes. Yeah. Shine it again. Right. Shine again. I magnified it. Yeah. Go. See, wire is in the center. So optimal. That's what we are saying. Good.
Okay, go. How high you went?
20.
Okay, go up again. Give me that 2.0 balloon now. Go
no, now you can go to bigger one.
No. 2.0.
No, you can go 2.5.
No.
Now you can go 25. Yeah, 20 atmosphere. You can go bigger now.
Down.
You open the circ. Yes. Your 3.0. 3.0 can go, which we had earlier 3.0. We had a 3.0. Let's do, because then we do the IVUS and then we are ready for our presentation. So call Daisy there. Hold it. Yeah. So we are going to, after opening with a 1.5, we are going with the 3.0. Yes. Tell that lady Olivia to get my website ready on this Zoom. Yeah, what a same thing. Somehow this a lot of audio disturbance
in my practical world also. Oh, why don't you like
Sorry.
What was the question?
We still could not hear well. Can we repeat the question, please?
Can you hear me now?
Good. So yes. This is our 3.0, which was the plan. Let's bring the other one back.
3.5.
That's a 3.5. So now question is, lot of people lot of people do a report and all this. I think once you do a kissing,
done.
It's okay. You've done a kissing. You already had done the pot. The logic behind the report, our paper just coming out in the JAC intervention, that the pot is done without much the scientific data.
Report.
Yeah. Go. So even otherwise, except the left main.
Yes.
Everybody has pot, but there is no data to support.
Down. Outside. Balloon is outside.
Yeah.
How high you went? Huh?
No, you go 20.
16, 18.
You are within there, 20. It's a good vessel. Yeah.
Okay, good. Down. Let me go inside.
Good.
Okay.
You go again.
Now,
12 atmosphere both.
Now both go 12. Yeah. Now we are good.
So always say that both of them don't go to very high pressure, because that's where you have the vessel rupture. Yeah. This is not 12, both of them.
Okay, good. IVUS.
Yes.
So individually we have dilated, and now we are going to show with the IVUS.
Okay, take a picture quickly. Ready?
Guide.
Go.
Good.
Good. Great.
Yeah, we're just going to make the IVUS now. Yeah.
Prof, if I can ask, as far as left main standing is concerned,
yes.
Is there a date if you have to come up to the ostium, or you're happy leaving the stent in the body of the left main.
I think if the ostium is completely normal, it's better, because I'll tell you why. One, you'll deform the stent many times with a guide catheter. Second, when patient comes back with the stenosis trouble, but if there is a little bit even dent, which I call a beaking, then you go up to the ostium. So I know in the Europe, they all want to go up to the ostium. We do not. We say that little beak, yes. In this particular case, right from the beginning, there was no disease in the ostial left main. You see that ostial left main was absolutely pristine. There was no beaking here.
Yes, yes.
So because of that, see that? No beaking. So in this case, we will just not come up to the ostium. Yeah. Okay, now where are you going now? Into the circ? Okay. I was into the circ.
Sure.
And we'll show that without doing the final report, will very circular lumen of the left main.
Yes, that will be great.
Yep, good. That's all you need. Too far. Okay.
Check the image.
Circumflex.
Yeah.
Flush.
Start.
Yeah, good.
Good. It's coming. Yeah, it's a native vessel. The blanch coming soon. Yeah, no, this is a ledge. Yeah, on the plaque, but no malposition, no dissection. Good area. It's a plaque circ. Now come to the osteocirc.
Looks good.
Yep. Then this is the left main.
Will be done.
Yep. Great area.
Okay.
Wow.
Very good. Okay.
Now come to the proximal left main. Yeah. No malposition. Yeah.
Very same wire.
That's circular.
Very circular. See that? And now we are going to do the left main to LAD.
Sure.
Oh. Good. Okay.
It should be 11. How much
Yeah,
is it?
12. Yeah. 11.5. Yeah.
This is left main is 12.
Okay, we are going into the LAD and then that's it. Done.
Yep. Yeah, so I think we thought that we'll come out with the one stent. We can take the circ wire out now. The one stent, but approach was clear that with that complexity, I think you have pay more price. Good.
Okay. Distal edge.
Okay.
Yeah.
Check the image. Coming back. This is the D1. Still native. Yeah.
Good.
Perfect landing zone. Yeah. This is a flux LAD nodular part. Eccentric shape, but lumen is good. And also the LAD, of course, great. Now coming to the bifurcation.
You see a nice crush of the circumflex.
Left main looks great.
Look at how good circular lumen.
Yeah.
Yeah.
Yep.
And see, ostium is not
Yeah,
covered.
not
That's
covered.
what we wanted.
No dissection, no
okay, with that note, if everybody agrees, we end our live presentation now. At this level, and two-stent approach is always better. You know, there is a recent paper from the Korea, from all the trials up to 10-year follow-up of the left main, iris main, pre-combat and so, and that also, best trial all showed that two-stent approach, of course, have a slightly higher TLR, but mortality point of view, at 10 years did better. It was the only one associated with a lower mortality with a two-stent approach. In these cases. So clearly, that using a two-stent approach, I still believer. Some people say, well, we go with the EBC1 approach with a stepwise provisional, but I think the two-stent approach with the lesion 011 or 111 is the right approach. With that note, we stop here, and we can show the last picture if you need to. And we just get ready for our presentation. And I'll join you in the next 5 minutes.
Show the last angiogram.
Show the last angiogram, yeah. And before that?
Very good result.
Yeah.
It's beautiful. It's beautiful.
Excellent result, sir.
That was the purpose. Beautiful. Okay.
Beautiful.
Thank you.
Beautiful.